Mary Jo, congratulations for so many years of service to Calhoun County, particularly at Marshall. Okay, and what an honor it is to have the Dale G. Griffin Lifetime Achievement Award. Some of us here remember Dale and his commitment and leadership to this community and healthcare. And he's someone we carry very close in our hearts. For now, he's been gone for over 20 years. And I just love how this community creates legacy. It's so important to us that we carry on and pass on to each other. So congratulations and thank you, Angela. As I begin the comments tonight, I think it's important that, and we're very fortunate to have Angela Myers on staff at the Community Foundation. And I want to take a moment because many of you knew Don Myers, which is Angela's father. And he unfortunately passed away a few weeks ago. So I just want us to take a moment of silence for somebody who gave so much to this community and was such a good dad to Angela. Thank you. Now that we've got those things over, we can drink wine and celebrate and beer and have lectureship and try not to get diabetes. Every now and then, I think it's just very, very important for us to go back and take a page back in history to understand how we got here tonight. So what did you say? This is the 41st Sherwood B. Winslow Lectureship. I've got to say, what community is the size of Battle Creek celebrates this type of lectureship for this many years, for this many times across the country? So we just have to reflect on that for a minute and think of how fortunate we are. And so I want to go back to how this started and how we got to where we are today. And then we'll get right into the lectureship from that end. So some of you can probably do this from memory, but Norm Williamson Jr., who was the grandson of W.K. Kellogg. And Norm was resided in California in his latter years, and of course he's passed away. But he was really good friends with a fellow called Dr. Sherwood Winslow, who was one of those outstanding local doctors in the old days in the community in our town, right? And Dr. Winslow's commitment to the profession, and I really want to speak to the residents here that are here tonight, because you're all sitting over there at the table, the Battle Creek residents. Just raise your hand if you're the Battle Creek resident. This history kind of repeats itself. But he got U of M to start a residency here at one time, way back before perhaps there weren't as much regulations around that, Dr. Stolberg, from today's world. But we are returning to a past that's very important to our future here in Battle Creek, and that has to be that we are a center of healthy behavior and healthcare at one time in this community. And I've seen that come back around, and there's so many leaders in this room and so many practitioners in this room that help make that we are on a path to becoming a healthier community from along that line. And we were the leaders in that at one time in this country from the standpoint of that viewpoint. So the lectureship was created by Norm Williamson in honor of his good friend and the good doctor in Battle Creek, Dr. Sherwood Winslow, from that end. And it was endowed at the Battle Creek Community Foundation since 1988. That's a long time for some of you. And not as many of you would remember 40 years of history as I do. So we have been doing this, and we've been doing sometimes 2 a year, sometimes 1 a year, and we've had a little bit of a break since 1988 for over 40 different lectures, and most of them are on your centerpieces there. We've been fortunate to have this kind of expertise in our community. So the goal of the lectureship is through the partnership with WMed, the Homer Stryker School of Medicine. For over 7 years, we were able to partner with that. And I was talking to the residents here a few minutes ago. In this room, somewhere 14 years ago, we got a commitment to continue to bring a residency. And then when Bronson Healthcare Group bought the hospital here, they continued that commitment to create a residency in Battle Creek. And why is that so important? Number one, it increases the acumen, the medical acumen in our community, which we so much need, and the access to those services. and are good partners with Grace Health. And the second point is sometimes when you have a residency here, you stay here. So we have a housing incentive program for our residents, and we're working on an incentive to give them jobs to stay here in Battle Creek. It's a progressive movement from that end, and we're so proud of our relationship with WMed from that end. So on behalf of the Battle Creek Community Foundation, we are extremely pleased that you're here this evening. We're extremely pleased about the history, and more importantly, we look forward to the future of our county and our people in it to having access to healthcare in a very difficult period in the healthcare industry. So thank you, Norm Williamson, and thank you, Dr. Sherwood Winslow. With that, we have Dr. Dan Stolberg here, who came in October, and he's not related to the Stolbergs from Marshall. I already did that, okay? I'm an expert in local communities. I'm not so good in big cities. But Dr. Stolberg arrived at WMed last October and immediately reached out to secure the partnership with us that we also enjoy here with WMed and with the residency and other things that we partner on. He's the chair of the Family Medicine and Community Health Department area for WMed. And he also works the Battle Creek residency. And I've heard from Dr. Stolberg, and I've heard from Dean Chamberlain. And now I've heard from the new CEO of Bronson Battle Creek, Joseph Dulac, who we're very thrilled to have working in Battle Creek, that we have a really good residency program. So I know nothing, but I take that credibility from them moving forward about where we stand and the platform we step off from tonight. Dr. Stolberg is going to come up and introduce our featured speaker for the Winslow Lectureship this evening. Thank you all for being here. Dr. Stolberg.
Thank you, Brenda, for that wonderful introduction, and my thanks to the Battle Creek Community Foundation for all the support to our learners in the community. And great to see so many of our learners here, and Dr. Pauline Hart, who is, her name is H-A-R-T, but she is, in addition to H-E-A-R-T, the heart of the Battle Creek residency program. She's put her heart and soul into that. So it's my pleasure to introduce Dr. Gretchen Wright, who I know because previously I was at the University of New Mexico. She did her training at the University of New Mexico. She is a doctor of pharmacology and then went on to do a residency for advanced training in pharmacology with specialization in cardiovascular pharmacology, and also in educating patients, residents, practicing physicians, professors in family medicine and across the spectrum in the area of diabetes, and also does research regarding the optimization of diabetes care and cardiovascular diseases, and also how to deliver those services to the community. When we were at the University of New Mexico, when we had a patient who needed extra help, Dr. Ray was our consultant. She was embedded in our clinics, at least 2 of our clinics at the University of New Mexico, a wonderful resource to the entire community and medical profession. She also has worked with the ECHO program, a world renowned program to help disseminate education through the use of technology and literally around the world through Sanjeev Arora. And so I will end my comments there and invite Dr. Gretchen Wright, who's coming all the way from Albuquerque, New Mexico. Thank you so much for being with us this evening.
All right, well, thank you for having me. It's really an honor to be here. So I was excited when Dr. Stolberg had emailed me. I'd actually never been to Michigan before, so I'm spending maybe 30 hours in total, but it's been pretty what I've been able to see. I wish I could have actually done some exploring while I've been here. So it's good to meet some of you. Just to give you another little bit of background about myself, I am a clinical pharmacist. I'm a pharmacist clinician, and in New Mexico, we have a different designation for certain advanced practice pharmacists that gives us prescriptive authority. So that's what that means. I function within my clinic as the physicians do, or the nurse practitioners, PAs. We all work together. I have my own panel. And then I'm basically like an embedded specialist within primary care. So the other providers, if they feel their patient needs the additional management, they send them to me and I take over that aspect of their care. allowing them more time to focus on the patient's other concerns for all of their other chronic conditions. So it's a team approach in our clinics, but it is the model in New Mexico with that license is a little bit different than in most other states. So today we're going to talk about optimizing outcomes in type 2 diabetes using the new and available pharmacotherapeutic options that we have. So here's our objectives. I'm going to be reviewing the 2023 American Diabetes Association Standards of Medical Care. This is where we get our big treatment algorithm for type 2 diabetes. So that'll be a little bit later in the presentation, but really I'm going to start with the background of how this updated algorithm came to be, what the data is behind some of these drugs that now are being used first line, and how diabetes management has changed substantially over the last 10 years. So we're going to talk about why that is and why we want to move forward and avoid clinical inertia, avoid using some of our older agents and start using these new medicines that can really help people. So these are, and I just also a caveat, I understand we have a wide variety of people in the audience. Some might be a prescriber themselves, some may be from the community. Many people, I imagine almost everyone in the room knows someone who's been affected by diabetes. So if you're currently in the healthcare field and you have the ability, you're prescribing, hopefully you can take this presentation and be an advocate for your patients and practice with these guidelines. If you're not in the medical field, hopefully you can take this information to help advocate within the community, with your family members, with your friends, to get them on the best medications that they can be on for their diabetes. So these are the current guidelines for diabetes from the Standards of Medical Care from the APA. These are updated annually. The publication comes out in January, but if you go to their website, they actually update it continually through the year as new data comes out. So there's constant changes to these guidelines. There's also a really useful app. If you are in healthcare, be sure to download that app. It's much easier than sifting through a 200-page document. But that's the image for the app. So why are we here? These are the diabetes statistics from the CDC. The CDC updates every 2 years. Their last update was actually 2021. That's what these numbers are from. So at some point this year, likely the new data will come out. But their last estimate was 37.3 million people in the US with diabetes. However, a large number of those are actually undiagnosed. And that's where it's automatically advancing. So we have it on a loop or something. So a large percent of these people are actually undiagnosed, and that's where involvement in the community becomes really important, to do screenings and education to try to find those that have not yet been diagnosed. And then under the surface, there's 96 million with pre-diabetes. So that's a very large percentage of the population that is at risk for developing diabetes down the road. So if we can work on prevention, that's even more important than treatment. So these are some state level statistics from the CDC. I just put up the Michigan statistics, the New Mexico stats, and the national statistics. And again, these are from 2021. New Mexico, diabetes is a very big problem in New Mexico. We have a really high risk population. You can see Michigan is also a little bit above the national mean as well. But I think I met with some members of the community today and was listening to them. A lot of similar challenges. Doesn't matter where you go, there are similar challenges people face with getting care for their diabetes or just with managing diabetes itself. So again, I'm a clinical pharmacist, so the purpose of this talk, we're going to talk about medications that are being used for diabetes. And there has been a huge shift in our goals when managing diabetes. In the past, it was all just about the blood sugar. You just needed to do whatever you needed to do to get their sugar down. And by lowering blood sugar and getting an A1C less than 7, we knew you could prevent microvascular complications of diabetes. But this has all changed. So now the way that you lower that blood glucose is just as important as getting it down. And even if somebody has perfect blood sugar, their diabetes care may not be optimized. And that's really what this talk is getting at, is that now we're not just worried about the glucose, we're worried about all of the other metabolic comorbidities. And how can we use medications for diabetes to help reduce cardiac risk and renal risk? So to prevent future kidney damage and to prevent cardiovascular events. So this is for anybody who's currently in the medical field right now. This is just a hypothetical question I'm not going to have you answer, but I want you to think about what you would do in this situation. So we have a 60-year-old male who has a fairly long-standing history of type 2 diabetes with an A1C of 8.2, and a history of an MI, and currently on metformin and empagliflozin, which is Jardiance. So just think about what you might add to the regimen. And we may revisit this at the end. This case, we'll talk about at the end as well. So just think, what might you do? This is somebody with an A1C of 6.8. So they're at their A1C target, their blood glucose is controlled. With a GFR of 50, elevated albumin to creatinine ratio, so they have protein in their urine, which is an indicator of some kidney damage. Currently taking metformin, glipizide, and they're on insulin. So would you make any changes for this person or not? And hopefully with the data that we present today, well, it may change your mind with what you might do with that patient. So we're going to talk about two different drug classes today. One of them we'll start with are the SGLT2 inhibitors, and these are drugs that work in the kidneys and are very kidney protective. This is a lot more detailed than most people need to know, so we're not going to jump into the detailed physiology here, but this is a nephron, and the SGLT2 inhibitors are blocking a transporter in the kidney. And ultimately, the end result is that they're increasing glucose or excretion into the urine. So I just tell my patients when we're starting these things, like you're going to be peeing out more sugar. You're peeing out extra sugar. That's the kidney's way of getting rid of this glucose from your blood. What we now know is that these drugs don't just affect the kidney or the kidneys. They have some really important effects on the heart as well. And that has changed the way that we're using these medications. So these drugs were developed for diabetes and with the purpose of working in the kidneys and helping getting rid of glucose through the urine. What they also do is work kind of like a diuretic or a water pill. So they reduce the amount of fluid in the body is one way to think about it. And they have some beneficial effects on the heart because of that. And that's what we're going to discuss through these next few slides is the data on the cardiac benefits of these medications and their kidney benefits. So these are the four main SGLT2 inhibitors that are on the market: canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. So a lot of people, if you're not already, you don't prescribe these or see them in healthcare, you might see them on commercials. There's even today when I was meeting with people, they all knew a lot of the names of these medications more just from seeing them on TV. So starting in 2008, every new diabetes medication, when they get approved, has to then undergo a large-scale cardiovascular safety trial. So they have to prove that they're safe and that they don't cause damage to the heart or cardiovascular events. When these studies started coming out for these medications, they not only demonstrated that they were safe, but they also demonstrated that they were protective. And that was not expected. I'm not going to go through all the data. This is a ton of numbers that we don't need to know. This is to prove a point. But these are four of the landmark trials that have demonstrated the cardiovascular protective effect of the SGLT2 inhibitors. So all of these of these agents, the first study to come out was the Wright study, and this was looking at empagliflozin. All of these trials looked to see if these drugs could prevent major adverse cardiovascular events. It's often referred to as MACE. And this is a composite outcome of non-fatal MI, non-fatal stroke, or cardiovascular death. And so empagliflozin, this first one here, was able to demonstrate a statistically significant reduction in that big all-cause outcome or composite outcome. The canagliflozin demonstrated the same thing. These two didn't demonstrate that composite outcome benefit, but what all of these four agents did show was a reduction in heart failure hospitalizations. So MACE is referring to like atherosclerosis, development of the coronary arteries leading to a myocardial infarction or a heart attack. Heart failure is referring to the pumping of the heart or reduced pumping of the heart. And so all of these agents reduce hospitalizations from that. And now they have started studying these same diabetes medications in people who don't even have diabetes. So this slide is showing you 4 trials where they studied these medicines specifically for heart failure in people with or without diabetes. And they showed the same benefit. So now these drugs are being used just for heart failure too. So they've gone from being strictly a diabetes medication to now being included in our heart failure guidelines as a standard of care for heart failure. In addition to the benefits on the heart, they have demonstrated a protective effect on the kidneys. So these are 3 of the big kidney trials, and we know diabetes is a risk, and one of the long-term complications of diabetes is kidney disease. And so anything we can do to prevent that or to slow the progression of kidney disease is important. So these 3 trials, which were done with canagliflozin, dapagliflozin, and empagliflozin, all 3 demonstrated a protective effect. They slowed the progression of this kidney disease. And because of this, these drugs are now being used for 4 reasons. Now, this is a big, busy slide, but all 4 of them initially were just for diabetes. Now, these 2, canagliflozin and empagliflozin, have FDA indications to reduce cardiovascular death, events and death in people who have diabetes and who are at high risk of cardiovascular disease or who already have cardiovascular disease. For heart failure, these 3 agents, canagliflozin, DAPA, and empagliflozin, all have a heart failure indication in people who have diabetes, but the 2 that are in red now are approved just for use in individuals who don't have diabetes and only have heart failure. And then lastly, for people with kidney disease, these drugs are getting approved for kidney disease in people with and without diabetes. So it's created this kind of bringing together a variety of specialty areas. These drugs are being used by numerous specialties. They're being used in primary care, by cardiology, by nephrology, and initially they were only for diabetes. So for those that are medical providers in the audience and might be prescribing these, one thing to keep in mind after we talk about all the great data on these drugs and how a lot of people are going to qualify for them because of their cardiovascular or their renal risks, you always still need to think about the safety precautions with these agents. Or if you yourself have diabetes or you have family members with diabetes, these are, I think, good points to always keep in mind. These drugs are increasing the amount of glucose in the urine. So it does increase the risk somewhat of urinary tract infections or of yeast infections. This is more problematic in people who have diabetes versus when these medicines are being used in individuals that don't have diabetes. So that's where we see the higher risk. These medicines do increase urination a little bit, kind of working a bit like a diuretic. So some people will notice that increase in urination and comment on that. They can lower blood pressure, which is good. That's kind of a good side effect. And lastly, they do cause a little bit of weight loss. And so oftentimes that's part of our discussion as we're starting these medicines, that people may notice small amounts of weight loss when they start these drugs. All right, so we're going to move on to our next drug class that's being used just about as much as the SGLT2 inhibitors. So these are the GLP1 receptor agonists, and I have this picture of the Gila monster up there because the first GLP1 receptor agonist to come out in the US was exenatide or Byetta. And this drug, they isolated the compound exendin-4 from the spit of a Gila monster. And they realized that was partly how the Gila monster is able to eat a large amount and they go for a very long period of time without eating again. And they always get that real big tail, and that's kind of then where they store their energy. So the exendin-4 was found and then turned into a therapeutic agent. So some of the newer GLP1 receptor agonists are different. They're more closely matched the human GLP1, but that's where it all started, was actually from the Gila monster spit. So we'll talk a little bit about the hormone that these drugs are affecting. These are GLP1 receptor agonists. So GLP1 is a hormone that our body makes when we eat. It's released when you eat food, it's released from the gut. And it goes on to have a variety of actions. Some of it gets broken down in the body after it's released. So we don't actually use all of your GLP-1. Some of it gets broken down. So in diabetes, sometimes they can become deficient in this hormone. And that can lead to high glucose levels. So just another pictograph of how this hormone is actually working. Again, it gets released from the gut. It acts within the pancreas, it acts on the beta cells and it increases insulin secretion. So this insulin secretion happens, but it only happens when you need it to happen. It's glucose dependent. So if you have normal blood sugar, these drugs will not cause the pancreas to start making insulin. That can cause a low sugar, but they don't do that. And that's partly why these are safer. They don't cause hypoglycemia. They also act on the alpha cells in the pancreas. They decrease glucagon secretion. And so when you decrease your glucagon, ultimately that reduces the amount of glucose production from the liver and the end result. And then almost last, this hormone works in the stomach and it regulates your stomach emptying. So it slows how quickly your stomach is emptying. And by doing that, when somebody's taking one of these medications, they feel full a lot quicker. This also can contribute to some of the side effects that we'll talk about here in a minute. But this is part of the reason that these medicines work on appetite. The other reason that they ultimately end up causing a lot of weight loss is because this hormone, GLP1, is involved in appetite regulation in the brain. And so by giving these medicines, we're giving this hormone at a really high level, and it ultimately significantly reduces appetite. So we see pretty large amounts of weight loss with the different drugs in this drug class. So these are the GLP1 receptor agonists that we have available. We've kind of had a progression over time as they've come out. From exenatide was our first one. These are all injectables. So exenatide was a twice-a-day injection, and it had to be timed with meals. But as things have progressed, it's getting easier and easier to use them. Then liraglutide came out, and that was only once a day. And you don't have to time it with meals. You could use it at any time of the day. Since that time, now we have our once-a-week agents. And this is huge. To only have to take a once-a-week injection versus giving an injection multiple times a day, not only facilitates better consistency with medications, but much better acceptance on the person who's living with diabetes, much better acceptance on their end. to only have to take something once a week and get similar effects to dosing something multiple times a day. So this drug, all of these drugs have also undergone those large-scale cardiovascular safety trials when they all first got approved. And we ended up seeing similar results as the SGLT2 inhibitors. There was this, with 3 of them specifically, there was this protective cardiovascular effect. So liraglutide, which is Victoza, semaglutide, which is Ozempic, and dulaglutide, which is Trulicity, have all demonstrated a statistically significant reduction in those major adverse cardiovascular events. So they all have the same cardioprotective effect. If we're going to choose an agent from this whole drug class, typically we're going to choose one that has the cardioprotective effects. So I always tell my students when you're studying for something, I was like, just remember the 3 that have the cardioprotective effects. Typically, that is going to be our first choice. So the GLP1 receptor agonists kind of have a similar history as the SGLT2 inhibitors. They were all initially just approved for diabetes, just to lower blood sugar. But now 3 of them are approved to reduce cardiovascular events in high-risk patients with type 2 diabetes. And now we also have 2 of them that are pretty strictly for weight loss, even in people without diabetes. And so liraglutide is approved under a whole different brand name called Saxenda, and semaglutide is approved as Wegovy. A lot of people have heard of these medicines. They're in the media, they're on social media, but they're very effective for weight loss. And they're approved even in people without type 2 diabetes. So this is just I always kind of like to talk about the devices, especially if you're going to be prescribing one of these drugs. I think it's really helpful to describe to the patient what they're going to be having to take. That's part of my role in my job, is teaching people how to use these. So if I'm the one doing the start or writing the orders myself, I always have my own demos to teach them how to do this. So if you don't have demos available to you, you can always have them talk to their pharmacist, their community pharmacist. Sometimes they'll have demonstration devices. But it's a good thing, I think, to look into your clinic, to have either your or other healthcare team members, your nurses, do this type of teaching. So 2 of our devices up here, the patient doesn't even see the needle. So the acceptance of these devices tends to be pretty high, even for somebody who's afraid or has a type of needle phobia or just general fear of injections. With Trulicity and Bydureon, they don't see the needle. It's all self-contained. These 3, Ozempic, Victoza, and Byetta, these are much more similar to insulin pens. Has anybody never seen an insulin pen? Yeah, somewhat. So this is what insulin pens look like too. They hold a small cartridge of the medication, of insulin, or in this case of these drugs, and the patient has to screw on a tiny little pen needle, and then they dial up their dose. So it's a lot easier than, in the past when people were on insulin, always having to use the vial and syringes. It's a much more difficult process, and it's more intimidating too than using one of these. And so fortunately, these GLP1 drugs have always come in these types of pen devices. So they've always been a lot easier to use. So a few last considerations for this drug class. We discussed the benefits. They have a low risk of causing low glucose or causing hypoglycemia. That's why they can be used in people who don't have diabetes. They don't cause low glucose on their own. They can cause significant amounts of weight loss. The amount of weight loss you see is actually variable depending on the drug. So they don't all cause the same amount of weight loss. Some it's more than others. We'll go through that in a bit. They, 3 of them, as we've mentioned, have that cardiovascular indication or cardioprotective effect. Additionally, I didn't discuss this data, but these medicines also have demonstrated some protective effects on the kidneys as well. Not as much as those SGLT2 inhibitors we talked about earlier, but they do have protective effect as well. So at the end of this presentation, we're going to talk a little bit about cost of these drugs, because oftentimes that is the barrier to their use. And sometimes that's the concern on the prescriber's end. I've heard this from the providers I work with. They're like, I don't even want to start this if I don't think the patient can get it, or if they'll be able to afford it. So we'll talk about how to navigate that to ensure people can get these medications, because they are expensive. They're very expensive if you don't have any insurance. So side effects, because they work partly on the stomach and slow that stomach emptying or gastric emptying, they can cause nausea. That's their most common side effect. So there's a whole way to minimize that or to mitigate that risk. I usually tell people when you start one of these drugs, I have them for the first week or usually first 2 weeks to, when they sit down with their plate, just cut it in half and only eat half of the food at first. And then to wait about 10 to 15 minutes to see how they feel. Because most likely they actually won't be hungry after that smaller amount. But when you're adjusting to that and learning those new satiety signals, most people will sit and eat their normal amount of food. And that actually could be too much and it can make the nausea worse. And so we talk about how to reduce that risk. And in general, most people end up tolerating it. But occasionally occasionally it's too much. Nausea will need to stop it. Contraindications, this is especially for those in here that might be prescribing these drugs. That I always have kind of a checklist in my mind before writing a prescription for one of these agents, to make sure you're reviewing their past medical history and ensuring that they don't have a history of pancreatitis, gastroparesis, or medullary thyroid carcinoma. Okay, so these are rare cancers, but I always review their risk for this before starting these drugs. And then the last drug we're going to talk about fairly briefly, it doesn't have the cardiovascular data yet, but it's brand new. A lot of people have heard about it. It's a dual GIP and GLP1 receptor agonist. So we talked about how GLP1 gets released from the gut when you eat. Well, there's actually 2 hormones like that get released. The other one is called GIP. And up until now, there hadn't been any drugs that were targeting that hormone. GIP and GLP1 have a lot of similarities on how they lower glucose and how they affect body weight, but they also have some differences. And so by combining those 2 hormones into one medication, when we look at the clinical trials, the outcomes that with the combined hormones is actually substantially better. You see better A1C reduction and better weight loss than with GLP1 receptor agonists alone. So the medication is tirzepatide or Mounjaro. I'll show you a few of its studies and how much A1C reduction they were seeing and how much weight loss they were seeing. But I don't really watch TV with commercials. I usually do streaming. So it's in clinic, my patients come in and they're like, I want Mounjaro about this. And so it's the commercial, people are really hearing about this medicine largely because they know weight loss that it's causing. So these are some of the primary tirzepatide trials. And I wanted to highlight the SURPASS-2 and the SURPASS-4 trial. So SURPASS-2, they were comparing tirzepatide versus semaglutide, which is Ozempic. And of the GLP-1 drugs, Ozempic is typically, when you think of Ozempic, is causing the most A1C lowering. So this was Ozempic, lowered A1C 1.86%. This was tirzepatide at the highest dose, the 15 milligram. So you can see the difference in A1C reduction. This is the tirzepatide versus insulin glargine, so versus a long-acting basal insulin. And again, you can see that difference in A1C reduction, insulin versus this agent. And it's important to remember that tirzepatide has now been compared head-to-head with insulin, but so have all of our GLP1 receptor agonists. They've all been compared to insulin as well and have demonstrated similar A1C reduction but without that hypoglycemia risk and with weight loss instead of the weight gain that you will see with insulin. These are the weight loss, some of the weight loss data from tirzepatide. If we look at this trial right here for PASS-2, where it was compared against semaglutide or Ozempic, those patients in their trial lost 6.2 kilos versus a little over 12 kilos with tirzepatide. So really big amounts of weight loss. And so now this medication is also being evaluated for an independent indication for weight loss alone in people without diabetes. And it does have some studies in those without diabetes as well. All right, so now we're through the drugs themselves. We're just going to talk about the actual treatment algorithm and where these drugs fit into it, so that you can know when to actually use these. Because there's this huge amount of diabetes medications available now. If you consider compared to 15 years ago, when you had metformin and the sulfonylureas and pioglitazone and then insulin. So that was all we had to deal with. Now you have all of this, but you have to decide when to use which one. So our current treatment algorithm is based off of the patient's other risk factors or their other comorbid conditions. So for every patient with diabetes, we need to think about whether or not they have clinical atherosclerotic cardiovascular disease, or ASCVD, whether or not they have heart failure, whether or not they have kidney disease. And if they don't have those three conditions, those three will dictate the therapy that we choose. If they don't have those three, then the guidelines say we should consider drug to drug. What is their efficacy on blood sugar lowering? What is their efficacy on their A1C reduction? And what are the weight management goals for this individual? So weight management and weight loss is actually a really big part of the updates in the 2023 guidelines. And this is because even small amounts of weight loss, even a 5% weight loss, is clinically significant on metabolic parameters. So just by losing 5% body weight, you will improve insulin sensitivity. And so that means all the other medications this person was taking, or even if they were already on insulin, it will start to work better if we can help them with some of their weight loss goals. This is a very busy slide, but this is the treatment algorithm from the ADA. So for the medical providers in here, this is why I recommend having the app so that you can zoom in on things. So we're going to kind of take this piece by piece. Sorry. This is the first section where we think about those core comorbid conditions, ASCVD, heart failure, or kidney disease, and how you choose therapy for those individuals to reduce their cardiac and their renal risks. So if the patient has clinical ASCVD, or if they're at high risk of ASCVD, then the guidelines recommend using this is along with metformin, or even starting this immediately at the same time as their metformin. So no longer do the guidelines say you should always start metformin first and then wait 3 months. This is like right away. This person should be on a GLP1 receptor agonist that has that proven cardiovascular benefit. So that's either liraglutide, semaglutide, or dulaglutide, or be on an SGLT2 inhibitor that has that cardiovascular benefit. And then after that, you would add the opposite drug class. So it's important to remember for this entire section of the guidelines is that the use of the GLP1 receptor agonists or SGLT2 inhibitors is independent of their A1C. So at the very beginning, I showed a case where the patient's A1C was 6.8. And one of the options for would you change anything was no changes are needed at this point. And that's what we want to move past. So we want to break that clinical inertia of saying they look good. From a glycemic standpoint, they look good. But are we giving them, if they actually are a high-risk patient, how we're lowering their glucose to 6.8 matters. And so at that point, you're actually still supposed to start one of these drugs may require modification of their other agents, but we need to get them on a cardioprotective drug, regardless of what their current blood sugars are. If somebody has heart failure, and this is actually with or without diabetes, this is now recommended. We want to start an SGLT2 inhibitor. So these drugs have been incorporated into the heart failure guidelines. They're part of quadruple therapy now for heart failure, regardless of diabetes status. So if you have a person with diabetes, A1C is 6.8, we would still initiate an SGLT2 inhibitor and maybe be able to even take off some of their other agents. And then if they have chronic kidney disease, so a GFR less than 60, or if they have albuminuria, so protein, so albumin in urine, the guidelines recommend starting an SGLT2 inhibitor strictly for kidney renal protection. Okay. After those, so I always tell the providers I work with, my students, everybody, every time we see somebody with diabetes, we need to ask those three questions. Do they have ASCVD? Do they have heart failure, or do they have kidney disease? And if the answer is yes, then we reevaluate their regimen and see, is this the best that they can be on, or should we do can we make changes to provide more protection? If they don't have any of those conditions, then we have a lot more, we can kind of use anything we want. And so it becomes more of a risk-benefit discussion with them on what might work best for them in their lifestyle. And the guidelines recommend thinking about the efficacy of each medication. And that's what this is getting at. So the guidelines now categorize our different drug classes by either high or very high, or intermediate level of blood sugar lowering. So why that's disappearing, but so very high, but they say will give you the most A1C reduction is either dulaglutide, semaglutide, or tirzepatide. And if you wanted to put those in order of the amount of A1C reduction you'll get, it's actually the opposite order. So it'd be tirzepatide, semaglutide, and the highest dose of dulaglutide. Those will give you the most blood sugar lowering. Insulin is very high also. So I always tell people there is nothing wrong with insulin. We have these other drugs that have a lot of benefits, but sometimes insulin is still the best option if they have very high glucose. And there's another treatment algorithm that will be in here more for your reference that talks about when to be initiating insulin. So in addition to thinking about the actual efficacy of the A1C reduction of each of these individual agents, they also recommend prioritizing weight management. So again, as I mentioned earlier, anything we can do to facilitate weight loss in somebody who needs that weight loss, whose BMI meets criteria, then we should use these agents that have that capability. So in the past, a lot of the diabetes medications cause weight gain. So insulin causes weight gain. Our thiazolidinediones like pioglitazone cause weight gain. So in somebody with diabetes, that's not optimal. If we can use one of these drugs, they will, in the long run, have better outcomes. And so the algorithm was changed in 2023. Again, focus on weight, and they categorize these medications by the amount of weight loss that they'll cause. So semaglutide and tirzepatide will cause the most weight loss. Dulaglutide or liraglutide is kind of the next level of weight loss. And we also, they just kind of work it down. And we do have weight neutral medications. So metformin is still our mainstay for diabetes, and it's weight neutral. And so we want to always keep the metformin on board throughout this whole process. We don't want to forget about that drug. This is another algorithm from the guidelines. So again, I recommend having that app so that you can use this in clinical practice. But this is the injectables algorithm from the ADA, where it talks about when and how to start insulin. And so I always recommend this. It's a very easy quick pocket guide for when you're needing to start or titrate insulin in clinical practice. But what has changed in the last couple of years is that the ADA now includes the GLP1 receptor agonist and now also tirzepatide in the, traditionally it was just an insulin algorithm. So now they put those drugs into this algorithm and just call it an injectables algorithm. And they do recommend starting those drugs in most people prior to insulin. If insulin is needed though, this is a really great resource to use to walk you through starting basal insulin and then moving on to mealtime insulin after. Okay, so what's a very important question that I get almost daily in clinic is about the cost of these drugs and how to figure out which one you can prescribe for your patients. So as I mentioned, these are both the SGLT2 inhibitors and the GLP1s, which are now being preferred in our treatment guidelines, are very expensive. That being said, they're still covered by all insurance plans. With Medicaid, each of those drug classes is covered. Usually they'll choose one agent. I was kind of scanning the Michigan formularies to just compare them to our Medicaid formularies, because usually your Medicaid formularies will be the most restrictive. And so I was just looking at some differences there. But all of your Medicaid plans have one of the once a week GLP1s on formulary. So and now I'm blanking if it was yours are mostly Trulicity. Yeah, ours have switched over to a lot of ours have Ozempic now. So and ours used to all be Trulicity. So it's a little bit opposite of the plans that I see more on New Mexico. But you've got that on formulary. Same with the SGLT2 inhibitors. The Medicare, for our Medicare patients, Medicare Part D is what's paying for the prescriptions. And all of the Part D plans cover these drugs. They have pretty good coverage. The issue with Medicare is that partway through the year, after Medicare has paid a certain amount, patients fall into a coverage gap. Sometimes it's called the donut hole. And at that point, they become responsible. They become responsible for about 20% of the drug costs. And 20% of a drug that costs $1,000 is a huge copay for somebody to all of a sudden have to pay every month. And so oftentimes with my Medicare Part D patients who don't have a secondary insurance, we really have to start brainstorming other assistance programs to keep them on the medication, because it sometimes is not affordable when they hit that coverage gap. And the next few slides, I have some resources on where you can go to help them get additional assistance to stay on their medications. For most of your HMO plans, like your employer insurance plans, these drugs will all be on formulary. Each insurance will cover one or two of them. But in addition, if I have somebody who has an HMO insurance, I usually will refer them to the whichever drug it is, to that drug's website, because there's always copay cards available to patients who have commercial insurance, and it will lower their copay. Say they pay a $45 brand name copay for any brand name medications. Each drug is different, but it's going to lower their copay anywhere from $0 for one of the two SGLT2 inhibitors, will drop them to zero, or about $25 a month. And that's what it is for the GLP1 receptor agonist. So it can save some people $20 to $30 a month if they just download this extra copay card and take it to the pharmacy with them. If somebody is completely uninsured, does not have Medicaid or Medicare, I've encountered a lot of situations where this might be temporary or it might be a long-term situation. We will use some of the older medications at this point that you can get for like $4 at a lot of community pharmacies. But if somebody has a specific indication for one of those more expensive medications, they have heart disease or they have kidney disease, we always will explore patient assistance programs through the companies specifically. So most of the drug companies will have these patient assistance programs that people can apply for, and they're going to be income based. And so we have a department that will help them with that application. Sometimes I end up helping them with it. They mail it in, and then we write a prescription along with their application. And if they get approved, they will get the medication shipped directly to them from the company for free. So I have several patients who have qualify for this due to their income level. Some did not have any insurance at all. Some had Medicare Part D, but could not afford their copays. So we worked through these applications to keep them on it. But in addition to that, we'll use some of our older, more generic medications, and we just, check different costs at different pharmacies to get them on the absolute lowest cash cost we can find. Additionally, insulin is also very expensive historically. This is changing now, and over the course of 2023, we're expecting all the insulin prices to really start to drop. Most of the companies have announced they're capping the costs of their insulin. Many states have enacted legislation to cap insulin copays. So there's been a lot of improvement in the cost of insulin. So this won't be as applicable, but it's something I always battle as well, is keeping my patients on the right insulins and making sure that they can afford it. This is more of a reference for you, so you can go back to these are the different programs for the SGLT2 inhibitors and the GLP1 receptor agonists, and where they can find those patient assistance programs online. So if you have resources in your clinic with either social work, or if you have community health workers or healthcare navigators, those are great people that help with this process so that people can afford the medications and stay on them. So with that, I covered a lot of information pretty quickly. What questions do you have?
So I know our insurance system is way too complicated, so we couldn't possibly have covered all the eventualities. Is Medicare, so I got 4 categories of insurance that you mentioned. If you have Medicare Advantage plan, is that more like Part D, or is it more like HMO coverage, or does it depend on who you bought your coverage from? If you're with the VA, what do you do? If you have TRICARE Prime, what do you do? And if you have TRICARE for Life, what do you do?
So that was one question. So let's start with the TRICARE. So the question was 4 more insurance situations, either TRICARE for Life, and what was your
TRICARE Prime is the under 65 age group, and TRICARE for Life is that.
right? Okay. So TRICARE itself has their own formulary, and we can look up their formulary just like any other plan. Oftentimes the VA system will also follow a similar formulary too, but TRICARE will be a little bit more expensive. So that works just like any other plan. TRICARE is usually not a concern with the cost. Medicare Advantage, I've seen it vary depending on the plan, but it will be similar to that. They'll have that coverage gap in most cases. Certainly Medicare Advantage plans also might have a deductible up front. Sometimes people are aware that they have that, and sometimes they're not. So I'll get a call and they're like, it's the beginning of the year, and they go in, they've not met their deductible yet, and all of a sudden their medication is $200. So they'll call and they're like, it's not covered. But I know it. I'm like, what? I know it's covered. I just checked their formulary. And so then when we look into it, it's because they didn't meet their deductible yet. So the insurance hasn't taken effect to lower their prescription costs until they pay a certain amount out of pocket. So that happens sometimes with the Advantage plans.
Won't be able to use copay.
So Medicare, if any government plan cannot use copay cards that you download off those websites, but Medicare patients can apply for the assistance programs that are income-based. They can apply for those, and so many of my patients who I've gotten on those actually have Medicare coverage, but unable to afford their copays.
Why does gaining weight, fat, adipose tissue in the belly predisposed to metabolic syndrome?
Yeah, the post-ulcer. So when typically when there's the abdominal fat accumulation, it's also accumulating surrounding the internal organs as well. And then leads to that worsening of insulin resistance. And so we'll have hepatic fat accumulation, and then fat accumulation even within the muscles, and that worsens the insulin resistance, predisposing to the development of diabetes.
I enjoyed your talk, by the way, but my question is, in somebody who has, with diabetes, who has microalbuminuria and is already on lisinopril, is there any additional advantage to, also being on an SGL2 blocker like Arcega, for example?
Yeah, that's a good question. So there is all of those clinical trials that I showed you on the SGLT2 inhibitors, they were on the standard of care, which is an ACE inhibitor or an ARB. So they were already on an ACE or an ARB, and then the SGLT2 was added to that. And the reduction in progression of kidney disease was on top of the ACE or the ARB. So this is add-on to ACE inhibitors and ARBs. Yeah.
For progressive kidney diseases, you mentioned that we should use these two. So what if we get into the limit where GFR is on the borderline, probably less than 30 or wrong that thing?
Yeah, so the question about when should you not initiate one of these? And that GFR cutoff has been changing over time. The most recent study to get published was the EMPA kidney trial, and they're looking at empagliflozin in people with kidney disease with really low GFRs. They actually dropped the GFR cutoff down to 20 to initiate for that trial. So now you can start, at least that one has the data, but we kind of extrapolate to the others usually. You can start it down to that GFR. And at least at our facility, if they're already on it, we'll continue it past that level, even all the way to dialysis. There's no data if they're in between that range of initiating, but EMPA kidney was starting people as low as 20.
And is that for both the GLP2 and GLP1?
The GLP1s, with the exception of exenatide, they're not renally excreted. So that you don't need to worry about dose adjustments for them, they're safe, so you don't really need to worry about it. But one thing to also keep in mind with the SGLT2 inhibitors, when their kidney function is that low, they're protecting the kidneys, but they're actually not having a whole lot of effect on their blood glucose. So their effect on blood glucose depends on renal filtration. So if the kidneys aren't working, the drugs can't lower glucose as much. So you're really using it more to protect the kidneys at that point than further diabetes. So.
Using the GLP1.
I'm sorry, what was that?
Are you using the GLP1 on high dose?
Yeah, so we are using the GLP1s on with people who are on high dose insulin. And yes, even if somebody's on high dose insulin, you can initiate one of those drugs, because ultimately what you'll see is a reduction in their insulin requirement over time. So when we do that, it requires very close monitoring, because we need to start to taper down the insulin, sometimes immediately. If their A1C is less than 8, when you're doing that initiation, you should proactively reduce their insulin by about 20%. And then I have people monitor really closely as we're kind of transitioning them, because they will need less insulin over time, and we want to be careful not to induce hypoglycemia, because now all of a sudden they don't need as much insulin.
I feel like the DPT4s had this like great little moment in the spotlight. And then the GLP1s came along. So I'm just wondering, we didn't talk much about it tonight. Are there indications of times that you preferentially use DPT4s anymore?
Yeah, so the DPT4s, I mean, they just don't have the cardiovascular outcome data or any weight loss, but really they're well tolerated. They don't cause as much A1C reduction either. So I use them mostly at times where if I don't have somebody that has a specific indication for one of these drugs, but they're close to target, and I want to avoid hypoglycemia. maybe an older patient who might be at higher fall risk, it would be really good for that because they're not gonna cause lows. They're not gonna cause any GI related side effects or they don't cause weight loss. And sometimes we don't want to cause weight loss in everybody. And so there is going to be a niche where that will be a go-to. Sometimes I have patients who don't tolerate either of these either. You know, we're not going to be able to use any medication for everybody. Everybody has a different sensitivity, and so sometimes the DPP-4 inhibitors are going to be a backup plan for me.
Right, for those medications that are all listed as being for contraindicated for type 1 diabetes, might they still have any protective benefits for kidney and heart for type 1 patients?
Yeah, so between the SGLT2 inhibitors and the GLP1s, both have been looked at in type 1. And GLP1 receptor agonists actually have some data in people with type 1 diabetes. We don't have the cardiovascular data though. There, we have there's weight loss data, some differences in insulin need if somebody has type 1 diabetes, but over time has begun to develop insulin resistance just with age or with weight gain over years. I've used type GLP1 off the label in type 1 diabetes in certain situations. SGLT2 inhibitors, though, they have been studied in type 1 because their mechanism is not insulin dependent, strictly working in the kidneys and causing increased excretion. However, there actually are safety concerns with using the SGLT2 inhibitors in type 1. So those we are still saying are contraindicated because they can increase the risk of, or type 1 diabetes patients are at increased risk of the euglycemic DKA side effect of the SGLT2 inhibitors. So that's one of their rare but known risks. And type 1 diabetes, we look at the cases of that happening. Oftentimes it wasn't somebody who either had type 1 or possibly even undiagnosed type 1. Where they may have initially been diagnosed with type 2, but actually had a lot of latent autoimmune diabetes of adulthood. And so that is a risk of euglycemic decay. So we do not want to use an SGLT2 inhibitor in somebody with autoimmune diabetes because they will not, eventually will have lost all beta cell function.
I'm a clinical care physician. I know these drugs, once the patients are hospitalized and safely stop them, how soon after the recovery, assuming full recovery, you generally see them back on these drugs?
Yeah, usually as soon as they go home, inpatients will usually keep them off until they leave the door. But as soon as they're home, they can restart. The SGLT2 inhibitors, for hospital use, one of the counseling points we do go through with people is that those need to be discontinued 3 days prior to surgery, because surgery also is now a risk factor for that euglycemic DKA. And so even on the outpatient side, if they're undergoing an outpatient surgery, we're still going to stop them for 3 days prior to the procedure. But then they can restart as soon as they're home and back on their other meds.
Is there any data that shows a use for Ozempic or that type of medication for substance abuse?
So I've actually looked into that because I've looked into it a few times in the literature just at safety. And I've had a few patients with alcohol use disorder where I was wanting to just double check safety. With the GLP1s, there's just case reports. There's not a lot of data or large studies yet. It did appear to be safe. I'd actually even found studies that showed lower alcohol consumption while on the medications. But no large scale studies at this point yet.
Yeah, I'm a psych pharmacist.
Oh, okay.
We see a little bit of that improved substance less substance.
Yeah. And maybe a lot of people just from a food perspective notice less food cravings when they're on the medication. So whether it's affecting cravings for other substances, to me theoretically, that's how it would be working.
I don't think this talk is a group for CME credit, but couldn't it be, maybe our connection with Debbie and Matt, you could get it.
I'll address that. Thank you very much. You are right. It was a fantastic presentation and I wish that it could be improved. Thank you. I agree that this was a fantastic presentation. Very medically appropriate. It's a matter of the rules for getting CME credit. We did not have our applications in time due to some logistical factors. So my apologies that we can't get CME credit for this. It's just a matter of my apologies.
Maybe next time.
Maybe that is our hope. We got this started. You're not. Thank you.
Any other question?
Diabetes causes lots of other problems, stroke, neuropathy, peripheral arterial disease, diabetic retinopathy. Do you have any data on preventing any of that or?
With these drugs specifically, I think agent specific. Yeah, with the impressive A1C lowering, you will ultimately prevent the microvascular complications, not the peripheral artery disease, but your microvascular complications will be improved with the larger drop in A1C. But I haven't seen any direct effects specifically on the nerve damage or the GLP1s actually. So semaglutide in its clinical trials actually had a small percentage that had worsening retinopathy initially. This is even seen in some cases with insulin. When you have a very rapid drop in glucose levels and an A1C, it can cause a worsening retinopathy, and that was seen in that in some of their trials. So that's something you kind of really watch out for. But I've not seen what I read direct data on these agents on individual complications like that. Right.
I'm not going to go too far because I have Bill Winslow with me here. And we just want to thank you for being our 41st speaker in the Winslow Lectureship. And we have a medallion that we'd like to present to you.
Yeah, thank you, Gretchen, and here's a medallion that we present to everybody, insignia and everything else. Put it on your desk and look at it every day.
Thank you very much.
Thank you very much.
So you can see up on the screen here, or if you would like to use paper, we have some paper to add your tables to provide a little feedback on the speaker for today. And so we appreciate the feedback that you provide us. A couple things is that we do have our local data on chronic disease, including diabetes and some of the other topics that we talked about today. A great way to look at that, if you want to look at Calhoun County, you can even get down to the census tracts, is on mycalhoun.org. We'll send out some information after the meeting as well, so you can all dive in a little bit deeper if you would like. But from that data and the work that we're doing, we're seeing some progress when it comes to our different community groups. We have both Rod Otten in the back there. You can give a little wave if you like. There you go. And Cicely McLaughlin here that are both on our PHA team and are leading chronic disease work groups in our neighborhoods. Rod over at Albion and Cicely here in Washington Heights. Where we have residents that are talking about strategies to address chronic disease, including diabetes. So if you'd like to get more involved in that, please stop and speak to either of them and they can get you connected. So thank you again, everyone, for joining us for the spring lectureship. We will be back in the fall with another speaker, and so there'll be more information coming out on that. If you did not receive information about the lectureship yourself and you heard about it from someone else, we have slips at the table that you walked in
That was right there when you walked in, and you can fill it out and we'll get you on our mailing list. So thank you so much and have a great evening.
Richard,